relazione del professor Rene Rizzoli, professore emerito dell'Università di Ginevra, che parlerà delle nuove terapie nell'osteoporosi. Grazie.
Buongiorno a tutti. Vorrei ringraziare la Fondazione Ferrero e il Comitato Scientifico dell'invito. Molto piacere perché i miei geni sono di qui. Un paio di anni fa sono stato invitato della Società Italiana di Endocrinologia e il convegno era qui in San Vincent, nel Val d'Aosta. E ho detto, non mi sento tanto bene di parlare in italiano per la relazione. E mi hanno detto, qui nel Val d'Aosta c'è due lingue ufficiali, c'è il francese e l'italiano. Ho fatto la mia relazione in francese, nessuno ne ha capito niente, ma è stato molto facile per me. Così oggi vado a parlare in inglese, se lei mi permette. No, è l'altro. Okay. When we speak about osteoporosis management, we should take into consideration not osteoporosis, not the disease, but the patient. And the aim is to reduce the expression of the disease, the complication of the disease, which is a fragility fracture. And classically, we have three pillars, triad, which is the nutrition, physical exercise, and pharmacological intervention. I will not today discuss at length both nutrition and physical activity, but just give you a few aspects. First of all, the pathogenesis of the fracture relates to two things. The first one is mechanical overload when we fall, and the fall is determined by several aspects: the sway, the walking speed, muscle strength, and neuromuscular impairment. And there are some data we collected a few years ago indicating that the brain is different according to the presence of sarcopenia or not sarcopenia. And the second component is mechanical incompetence, osteoporosis, and we know that bone fragility is determined by the mass, by the degranulation, with the geometry, the microstructure, and even the material level properties, how the bone tissue is built. And this leads to the fracture, and then the fracture repair, rehabilitation, and finally, we have to prevent any further fracture. And the three pillars are affecting all these steps, particularly nutrition and physical exercise are influencing all the two components, while pharmacological intervention maybe is more devoted to bone. There is some suggestion that maybe some of the anti-osteoporosis drug could influence the fall, but it's still debated. Now, if we move to nutrition, I will not discuss calcium, I will not discuss vitamin D, but I will discuss very rapidly a food, not nutrients, a food combining both calcium and vitamin D. And we have this trial, which is probably the largest in the field of nutrition, in terms of randomized control trial with approximately 7,000 elderly recruited with a mean age of 86 years. This was done in Australia. You see with a normal vitamin D status. And there was, in some nursing homes, some dairy product supplements, and in some nursing homes, just the standard food. And you see that this dairy supplement led to an increase in calcium from 700 milligrams per day to 1,100, and the amount of protein from 0.9 to 1.1. It was what was recommended just before by Professor Zamboni. And if you look at the data, they are very impressive because you have a 33% reduction in the rate of fracture. You have 46% in the risk of hip fracture. So just this supplement given to all individuals is able to reduce the risk of fracture and particularly of hip fracture. But you will say, well, dairy products are containing some fat, and maybe it's not so good for the cardiovascular system. And here I'm surprised, but I'd like to remind you that the dairy products consumers are not exposed to higher risk of hypertension, not higher risk of stroke, and not a higher risk of coronary heart disease. Even for the two former variables, it seems to be a little bit protective, but I don't want to stress out that you treat hypertension or you prevent stroke by giving dairy products, but at least it's not associated with a marked side effects. If we move now to physical activity, particularly for the prevention of fracture, there are some there are some meta-analyses, numerous, I would say. And all of them conclude to a small effect, but provided first, as shown on that one, that the physical activity program is supervised by a physicist or by a doctor. If you don't have supervision, you don't see anything. Then you need a progressive exercising. If you just do the same every day, you don't see an effect in terms of fracture. And finally, it should be at least 1 year of treatment before you don't see anything. And the question is, how much should we prescribe? How much should we advise in terms of activity? And here, the problem of adherence is certainly present. If you look here, this very few weeks ago published recommendation, and you look at the frequency, at least 3 times a day resistance training, at least 7 days, every day some balance training. I know that nobody is like Professor Isaiah running every day. And most of our patients are sedentary, and we try to convince them to develop some program. But you see, it's very, very, very difficult to convince them, even if you are very persuading, it's difficult to follow such a program. So there are something which is probably simple, and this is what we call the Jacques Dalcroze arrhythmic. Jacques Dalcroze was a composer, a French composer, who lived in Geneva for all his life, and he was a composer of operas, but he invented a technique which is called arrhythmic. I did that at school. It was boring. I prefer playing soccer. But it's a technique in which there's somebody playing piano, changing all the time the rhythm of a piano. And then there are some exercise like dance, but dissociating the upper and lower limb movement. And in this trial, it was 1 hour per week in a randomized fashion. And you see highlighted in red the risk of falling after 1 year. It was reduced by approximately 50%, indicating that even 1 hour a week with all the social interest for this patient to come to this 1 hour school of arrhythmic, it was associated with a reduction in the risk of fracture. And in terms of mechanism, on the right side, you see that it was possible to detect a lower stride length coefficient of variation, so the walking was more regular. And if you look at the velocity, the walking speed, it was slightly higher. So this program at only 1 hour per week was efficacious in terms of reducing the risk of fracture. Now, if we move to the different drugs in terms of anti-fracture efficacy, all these drugs have been tested in randomized controlled trial with a fracture as the primary outcome, except maybe for the estrogen. And they are classified into anti-resorptive or anti-catabolic or bone resorption inhibitors. And they inhibit the osteoclastic bone resorption. I will come later. And you have the second category, which are the drugs stimulating new bone formation, building new bone. And here we have the parathyroid receptor activators, teriparatide and abaloparatide, and a sclerostin inhibitor called a monoclonal antibody called romosozumab. And we have a large variety of treatment. And to answer the question by Patricia, we could offer to the patient which type of treatment they prefer. We have oral, intravenous, subcutaneous. We have daily, monthly, 3 monthly, 6 monthly, or yearly regimens. So we could play with that. Now, in terms of osteoclast, as you know, the osteoclast is a cell within the bone, destroying the bone. But before being a cell, it's an instrument invented by Francesco Rizzoli in 1872. It was this instrument to break the bone because he was an orthopedic surgeon in Bologna, and he received a lot of patients with a leg shorter than the other. And what he did with this instrument, with this osteoclast, he was breaking the bone with a higher length to reduce the length of this bone, and he called that the osteoclast. But the osteoclast we are dealing with today are the bone cells. Now, if we look at the efficacy first of the bisphosphonate, and I wanted to show you this slide because the bisphosphonate we are using, it was called a blockbuster several years ago with $2.6 billion of sales. It's probably the drug with the longest development. The first time that a diphosphonate was mentioned, it was in 1968. It was an abstract. But the discovery was large enough because the next year there was 2 papers in Science and 1 in Nature on bisphosphonate. But at that time, it was considered only as a physical, chemical aspect, inhibiting the growth of mineral, promoting the dissolution. And it was by chance, by serendipity, that 10 years later it was discovered that this bisphosphonate had an effect on the cells. And in 1976, I was in the lab when this lady, Diana Fass, who was a postdoc from Australia, came, and she was very excited because by chance she put a little bit of bisphosphonate on the chondrocytes in culture, and she showed that the metabolism of these cells were changed. But then there was 10 years later the beginning of a nice story, the alendronate story, which was led by Gideon Rodin. You see the slide here. And this was a drug invented in Pisa, Italy, by the family Gentili factory. And what the Merck company did at that time, they bought the patent for this drug, they bought the factory, they bought the company. So the contribution of Italy through this Pisan family is very important, since alendronate was the first bisphosphonate with a clear anti-fracture efficacy. And then we had to wait nearly 10 years to see the mechanism of action, and actually 3 different groups concurrently demonstrated what it was doing with 2 categories of bisphosphonate, one transformed into a false ATP, and the other one affecting some metabolism in the cell, the synthesis of cholesterol in the bone-resorbing cells. And here, the efficacy of this bisphosphonate has been demonstrated. You see here the effect on the 4 bisphosphonate still on the market now in terms of vertebral fracture. And you see they are reducing the risk of vertebral fracture between 60 and 70%, indicating a very efficacious effect. But the point I would like to make, and this is to complete what Patricia said before, you see that the effect of this bisphosphonate were already detectable by only 1 year of therapy, and this could be envisaged in patients with a relatively limited lifetime. Then if you look at the non-vertebral fracture, the reduction is between, let's say, 20 and 30%. And if you look at the main catastrophe in terms of fracture for the patient, the hip fracture, you see here the possibility of a reduction between 40 and 50%. So you reduce 3 out of 4 fracture for vertebral fracture, and you reduce approximately 1 out of 2 for hip fracture. But we have other bone resorption inhibitor, and this bone resorption inhibitor is in this case a monoclonal antibody directed against a factor which promotes the number of osteoclasts and promotes the activity of this osteoclast. And this compound is given every 6 months subcutaneously. It's very easy, nearly without any side effects locally. And the efficacy in terms of vertebral fracture on the left is very high, minus 68% after 3 years. For the non-vertebral fracture, 20%, so you avoid 1 out of 5 non-vertebral fracture. And if you look on the right-hand side to the hip fracture, in this case, you reduce by 40%, nearly 1 out of 2. This treatment has been conducted in randomized trial up to 10 years. It's efficacious. But one of the problems is when you stop this therapy, in this case, there's a rebound in terms of bone resorption with a risk affecting approximately 10% of the patient of an increase in vertebral fracture, and particularly an increase in multiple vertebral fracture. So for this reason, although the data are not very strong at the present time, it's always advised to switch when we want to stop this therapy, to switch to some bone resorption inhibitor with a longer action like the bisphosphonate. The next point now is this is a meta-analysis showing the efficacy in terms of non-vertebral fracture and non-vertebral fracture for these bone resorption inhibitors. I was showing you the data before. But the second category is the so-called bone building or bone formation stimulating agents or anabolics. And you see on this slide that overall, it seems that the data are on the left side of the bone resorption inhibitor, suggesting maybe a higher efficacy in terms of reduction in fracture risk. And I will come later. But the issue now is we have which is rare in medicine, to have a treatment which reduces the complication by 50 to 70% regarding vertebral fracture, even 96% for multiple vertebral fracture, and hip fracture 50%, non-vertebral fracture between 20 and 53%. But for patients at very high risk of fracture or imminent fracture, we need something more efficacious, acting more rapidly, and with a magnitude of effect maybe larger as compared with the bone resorption inhibitor you have seen the data of just before. And here the possibility is because, particularly for the so-called imminent fracture, we know that one fracture is a very high risk for second one. But something which is most of the time ignored is this risk is much higher during the first 2 years. If you look at the left side of this slide, this is a cumulative risk of a fracture, any fracture you see, and the curve is much steeper during the first 2 years, indicating that you have a higher risk after an incident fracture as compared to later. And on the right-hand side, the same types of data translated in this case in relative risk. And you see that overall, we have a doubling of the risk when you have got a fracture for subsequent fracture. But during the first 2 years, this risk could be fourfold higher, indicating that we have to intervene as soon as possible. And then in terms of a definition of the so-called very high risk, we have different societies. They are not agreeing, although when you have a very, very low bone mineral density, yes. When you have multiple fracture, yes. The first one is the American Society of Clinical Endocrinologists. The second one is the US Endocrine Society. The third one is the Bone Health Osteoporosis Foundation, the former National Osteoporosis Foundation in the US. Then the NOG is a group in UK. And finally, IOF is the International Osteoporosis Foundation, LSKO, European Society for Clinical and, well, I don't know, it's a relatively complicated name, although I'm chairing the scientific committee of this society, I should be aware of. But what we retain in this last series of companies, it was to have a risk 25% above the age-specific intervention threshold or imminent fracture risk. And why that? It's because we discuss a lot, and there is some, I would say, agreement when you have in front of you a patient with a fragility fracture, particularly a fracture of the vertebrae of the hip. Nobody will contest that some therapy is justified. So what was done here using this algorithm, it was to translate this conviction, this agreement, into some risk of fracture. And the line which is in the middle is the risk of somebody at a given age equivalent with the risk if this person had a vertebral or hip fracture. And then you take this risk, which is provided by the FRAX tool, which is calibrated for each region, for also the mortality in each region, for the incidence of fracture in each region, and then you add 20%, which is approximately the 95% confidence interval of this value, and then you define the very high risk groups. But this different definition is not to comply with our, I would say, theory, but it's associated with some consequences. If you are in the green, the low risk, you will prescribe a little bit calcium, you will prescribe some vitamin D, and you will maybe prescribe some physical therapy, and in young women, you could prescribe menopausal hormone therapy. Then, if you are in the middle, the so-called high risk, in this case, you still optimize calcium and vitamin D. You still try to introduce some fall prevention program. But in this case, you will consider the possibility of bone resorption inhibitor, oral bisphosphonate, intravenous bisphosphonate, or subcutaneous denosumab. And then, if you are dealing with a patient called at a very high risk or imminent fracture risk, in this case, you could consider something which is stronger, acting faster, quicker. And in this case, we could consider the possibility of a bone formation stimulator. And why I'm saying that? It's because for this bone formation stimulator, there are face-to-face trials comparing a bone resorption inhibitor, bisphosphonate, and one of these compounds. I will just show you some of these trials. The first one is compare teriparatide, which is an analog of PTH, the amino terminal part of physiologic PTH, compared to risedronate, one of the bisphosphonate. And you see on the left-hand side the incidence of new vertebral fracture, and you will absolutely agree that in a randomized controlled trial with at baseline exactly the same patient randomized in either group, you will say that the blue is lower than the pink, indicating that teriparatide is stronger, has a higher efficacy in terms of vertebral fracture reduction as compared with risedronate. And if you look at the right-hand side, this is the first clinical fracture, so a fracture associated with some complaint, and once again, there is some dissociation. Now, if you look at the second compound interacting with the PTH receptor, which is abaloparatide, which is an analog of parathyroid hormone-related protein. This PTH-related protein is a compound we have all, which plays a role during pregnancy, which plays a role during lactation, but in some cases, it's produced by some tumor contributing to the hypercalcemia of malignancy. But there is some analog, once again, of the amino terminal part of this compound, and it has been shown to reduce the risk of fracture. And here, it's not exactly a face-to-face, but it's comparing two periods of the same trial. But if you look the green, which is abaloparatide, to the light blue, which is alendronate, once again, this compound is associated with a low risk of vertebral fracture as compared with the bisphosphonate. And finally, the third compound I wanted to allude to is romosozumab. And romosozumab is a monoclonal antibody directed against the sclerostin we all have in the bone. And sclerostin is an inhibitor of bone formation, a natural inhibitor of bone formation, and a activator of bone resorption, slight activator. So when we give an antibody against this sclerostin, you will remove the inhibition of bone formation, so you will have a higher formation, and you will remove the small stimulation of bone resorption, so you will decrease bone resorption. And this compound has been tested against in a placebo-controlled group first, and you see here the effect not against placebo, but the effect against alendronate. And there was, once again, a higher potency, a higher reduction in the fracture risk in the first line in terms of vertebral fracture, in the second series for clinical fracture and non-vertebral fracture, and this dissociation. So this romosozumab is affecting the bone in a stronger way as compared with a bone resorption inhibitor, in this case, alendronate. A point I'd like to mention as well, in this trial, the mean age was 74 years, and 52% of the patients were older than 75. But there was one aspect here which was like a drama in the field of bone. It seemed that there were more severe cardiovascular events, at least in one trial, with romosozumab as compared with placebo, or with alendronate, sorry. And for this reason, there is some warning. It should not be used in women with previous myocardial infarction or stroke. This was proposed by the FDA, but also with the European Medicine Agency. We could discuss this issue later, but because there is some explanation for that. But I will continue by asking a third question. And this question, when you give this bone formation activator, when you give these anabolics, you have a large effect, larger as compared with a bone resorption inhibitor, but the offset of action is much higher. So the effect disappears very quickly. And if you look here for teriparatide on the left-hand side, after 18 months of treatment, the patients were left. And some of them were prescribed a bisphosphonate for any reason, and some were receiving nothing. And you see on the left-hand side the evolution of bone mineral density. For those receiving a bisphosphonate after teriparatide, there was the maintenance of the increase in bone mineral density, even a small further increase, while for those receiving nothing, there was, by 30 months, no effect anymore. And the same could be detected with abaloparatide, but in this case, with a trial specifically designed to answer this question. So for the first line, this is a vertebral fracture during abaloparatide. After 6 months of alendronate following abaloparatide, and then 23 months later. So you see here that you can maintain and even further reduce the risk of fracture by having some sequential therapy. First, a bone formation simulator, an anabolics, followed by a bone resorption inhibitor, either the bisphosphonate or denosumab. And for romosozumab, it's the same. You see here the efficacy of the fracture, on the vertebral fracture, followed by, in this case, denosumab. So we have to add, after the 18 months or 24 months of a bone bone formation stimulator, we have to add a bone resorption inhibitor. Now, the next question is, what are the overall efficacy in terms of numbers? And on the right-hand side, highlighted in red, you see the efficacy of this regimen, abaloparatide or romosozumab, followed by a bone resorption inhibitor, on vertebral fracture. The efficacy is between 66 and 87% reduction, so it's fantastic. And for non-vertebral fracture, it's between 21 and 52, indicating that it's a very strong, efficacious way to reduce the risk of fracture in your patients. But as shown before by Patricia, osteoporosis is under-recognized and undertreated. And we could ask the question, what are the different reasons? The first one is because we don't know what are the targets when we introduce some therapy, because to reduce the fracture risk, it's not detected. A fracture occurring under therapy, it's not because the therapy is wrong, it's because you are not in 100% risk reduction. The duration of treatment is a debate since decades. Under recognition of the fracture risk associated with an incident fracture, and once again, Patricia showed the so-called treatment gap. We have patients coming with a fracture, so the diagnosis of fragility fracture is here. You don't need any further investigation, but still 3/4 of the patients are not receiving any treatment. Then to answer too late to intervene, Patricia has answered that. It's never too late. Fear of side effects, it's always there. And in terms of regimen, as I said before, we have daily, monthly, 3 monthly, 6 monthly, yearly, and so on. So it shouldn't be a major problem. Now, regarding the target treatment, we treat the patient and we ask the question, but what is the aim? And this was indirectly answered a few months, years ago, with this combination of all the trials with the fracture as a primary outcome. And this group in the US and in UK, what they did, they related the reduction in the fracture against the change, the increase in bone mineral density at the hip level. And as expected or as hypothesized, the higher the increase in bone mineral density, the lower the risk of fracture. But from this very large number of patients, it was possible to have some 95% confidence interval. And then when this 95% interval on the right-hand side is crossing the horizontal line, you have a certain percent. And from this calculation, you could say, well, if my patient is gaining more, in this case, 1.4% in total hip bone mineral density after 2 years, in this case, the chance of having a significant reduction in the risk of fracture is very high. So with this type of approach, we have some target for the patient to try to convince them, since BMD alone in absolute value is maybe less efficacious as compared with this relative increase in total bone mineral density. Now, in terms of discontinuing therapy, there is this wrong name called holiday, but it could be discontinuation. And sometimes, after a while, the patient is tired, the doctor is tired as well to continue therapy, and we need some criteria to say, well, maybe we should stop therapy. And in this single center, they stop therapy, and then they categorize the patient in 3 groups. The first one called low risk, in this case, bone mineral density was relatively normal after the treatment. The second group called moderate, in this case, bone mineral density was a little bit above minus 2.5 standard deviation, but there was some history of fracture. And the high risk group was those with a clear osteoporotic bone mineral density and with fracture. And when they follow this patient over time, you see that the green, so the low risk, it was nearly no fracture occurring, but in brown, the so-called high risk, in this case, there were many fractures. So with this type of approach, when you are a doctor with the patient in front of you, you could say, well, we have reason not to stop therapy, maybe, but if you are in the category of the high risk, in this case, you should continue. Patricia alluded to already regarding the gap, but depending on the country, depending on the reimbursement policy, this trap is very much different. On the left side, these are the so-called three main European countries, or four main countries. And you see here it's between 50% and 85%. In terms of treatment, non-treatment after hip fracture, and nobody contests that a hip fracture is clearly a fragility fracture, an osteoporotic fracture. Maybe the better score in UK, it's because there was some issue that the reimbursement of the hospital stay was done if there was some treatment introduced. So you see, with some incentive, it's possible to improve that. But on the right-hand side, in different, it's not only in Europe, you see in US, in Korea is a little bit better. And in this case, you have a possibility to improve, and this is the so-called Capture the Fracture campaign, which was conducted by the International Osteoporosis Foundation. But this issue of treatment after fracture, particularly hip fracture, is a very important point because you see, it was published a few days ago, the WHO benchmark for equitable hip fracture care, and there are two criteria to see and to compare the health system throughout the world. And the first one was the proportion of the patient operated on within 48 hours after the fracture. And the second one is the proportion of the patient receiving some specific anti-osteoporotic treatment after the fracture. But this campaign now is very well spread out with nearly 1,200 centers throughout the world. And up to now, it was September 30th, so 1 month ago, there were close to 1 million of patients involved in this trial. And we very much hope that it will be extended. And in terms of efficacy, there are several meta-analyses, and just I show you one, that if a patient is included in this program, the Capture the Fracture program in the frame of the so-called fracture liaison services, there is a 32% reduction in subsequent fracture and even a small effect on mortality, and all the cost effectiveness evaluation are positive. For instance, this program are led by a nurse, and the yearly salary of a nurse corresponds to 3 hip fracture treatments. So this means that if you avoid 3 fractures, you have paid the nurse conducting this program. I will skip that because it was the efficacy in the oldest old. And I will finish by saying, well, the research is continuing, despite the fact that you have seen the efficacy of this drug, how easy they are to administer. But in terms of monoclonal antibodies, there are at least now 8 different biosimilars, hopefully cheaper. We have a new antibody which is now in phase 2, which is very interesting because this antibody is directed against both sclerostin and another compound which is a bone formation inhibitor called DKK1, and this compound is increased in multiple myeloma. There is another anti-rank ligand. It was not developed, blazozumab. We have hormonal agents under development, and particularly a new PTH analogs which can be taken orally with some specific effect, particularly on bone resorption. And we have all this category of the so-called senolytic, which are thought to reduce senescent cells by specifically targeting these cells. And there's one trial already developed by the Mayo Clinic, combining both dasatinib, which is a tyrosine kinase inhibitor, and quercetin flavonoid. The data are not very convincing in terms of magnitude of the effect, but they open the door to future research. And we have also the last series here, a little bit more biochemically oriented, and I don't want to go into details. And we have a series of different compounds which were tested but removed from the development, and you see here the so-called former potential candidates, but there is some opening with the gut microbiota modulator. And here I will end up with reminding you something which was published more than 100 years ago. And this was this Nobel Prize winner in 1908. And he said that health could be enhanced and senility delayed by manipulating the intestinal microbiome with host-friendly bacteria found in yogurt. So yogurt is not only good for preventing the fracture, you have seen the data before, but maybe it could contribute to a better microbiome and a better bone health. I thank you very much for this attention, for your attention. And our vision at IOF is a world without fracture in which healthy mobility is a reality for all. Thank you very much.
Passo subito la parola al professor Isaia.
Thank you very much.
Sia per la discussione che per le conclusioni.
Thank you very much, René, for your beautiful presentation. Ci sono delle domande? Any question from the audience? I have a question, a very practical question. What do you say about the ONJ complication of the treatment by bisphosphonates or denosumab?
Well, on purpose, I hadn't time to cover that. There were, a few years ago, two psychodrama. One developed by the dentist because they had the first cases of osteonecrosis of the jaw. And when you get the first cases, you think that it's very common. And at that time, they didn't know how to treat them. So there was some very bad surgery with removal of half of the jaw. It was very much a catastrophe. But finally, with register, with systematic recording, it seems that this risk is relatively low, affecting between 1 out of 10,000, 100,000 patients a year. And there are recommendations to reduce this risk, not to have surgery in the mouth, avoid some tooth extraction, and particularly to increase hygiene in the mouth. And with that, the risk is very low. The second psychodrama in this case was developed by orthopedic surgeon, was the so-called atypical fracture, which is a very strange fracture occurring even without a fall. And this fracture is preceded by some pain in the leg. The X-ray image is very different from the so-called non-atypical, and it seems that the risk is time-dependent. The longer the treatment, the higher the risk. But once again, if you look at the real incidence, is relatively low, very, very low after 1-2 years of treatment, relatively low after 5 years, and in this case, there is still a 30% or 30-fold increase or decrease, as you want, in terms of reduction of hip fracture as compared with the risk of the so-called atypical. And 1/3 of this atypical fracture are occurring in patients without bisphosphonate and without denosumab. So it's not specific, but clearly the risk is associated.
Professor D'Amelio, last question.
Thank you very much for a beautiful presentation. As we are talking about the risk, what about the risk of rebound when you stop denosumab?
Yes, I alluded to. So the risk with Swiss data, it's 10% of the patients discontinuing denosumab who are developing one or multiple vertebral fractures. So we have something to do.
Bene, thank you so much. Again. Allora, concludiamo questa sessione. Devo dire, sono molto soddisfatto della scelta dei relatori, del livello delle comunicazioni e delle relazioni. Per fare le conclusioni, direi che sono emersi alcuni concetti pratici che vorrei tradurre. Intanto che l'osteoporosi è una malattia curabile, nel senso che i dati hanno dimostrato che l'incidenza delle fratture si riduce notevolmente in modo variabile a seconda delle casistiche, a seconda dei farmaci, comunque bisogna trattarli. L'atteggiamento di non trattare è un atteggiamento assolutamente non professionale e che quindi bisogna assolutamente combattere ed evitare. Abbiamo detto prima, è una battaglia persa, ma noi, come dire, ci piacciono anche le battaglie perse. Poi una malattia sottovalutata, nel senso che molto spesso capita di trovare pazienti che non vengono trattati perché sono vecchi. È vecchio, cosa vuole mai? Insomma, questo è il limite dell'ageismo, che in alcuni paesi è anche sanzionato penalmente come atteggiamento clinico, e quindi l'ageismo non va bene. Tutti i pazienti hanno diritto ad essere curati, ma a fronte di questo sottotrattamento c'è anche un sovratrattamento in pazienti che magari hanno un rischio modesto. Questo è stato dimostrato soprattutto da quando una nota azienda che produce densitometri ha scritto nel referto, a fronte di una densitometria sotto meno 2,5, high risk fracture, che è concettualmente sbagliato, deontologicamente scorretto, professionalmente non ammissibile, per cui non fidatevi di queste scritte, andate a fare gli algoritmi del rischio, come è stato detto ripetutamente. Quindi l'atteggiamento verso l'osteoporosi va radicalmente cambiato se vogliamo fare del bene ai nostri pazienti, soprattutto se vogliamo assicurare loro una vecchiaia accettabile. Inoltre, per quanto riguarda la sarcopenia, anche questa è una malattia sottodimensionata, trascurata, ma molto frequente, e che ha con l'osteoporosi dei rapporti fisiopatologici molto complessi. Ne ha accennato il professor Zamboni, ma direi che alcune cose non sono ancora ben note, tant'è che qualcuno pensa che sia una malattia unica, osteosarcopenia, ma comunque va affrontata in modo adeguato, come è stato detto ripetutamente. Sull'atteggiamento olistico ne abbiamo detto ripetutamente, la relazione del Roberto Pacifici ha aperto un spaccato su questa roba. Chi mai immaginava qualche anno fa che l'osteoporosi fosse influenzata dall'intestino, no? Ma ce ne sono anche altri esempi in cui l'osso è la vittima di situazioni fisiopatologiche complesse che arrivano altrove, quindi chiaramente occorre questo atteggiamento, diciamo così, verso la salute in generale del paziente, curare il malato e non la malattia, non si cura la densitometria, non si cura il malato, quindi va considerato nella sua complessità, nella sua articolazione biologica, non trascurare l'osteoporosi secondaria, è stato appena accennato, ma anche questo è un punto delicato. Quante volte è capitato a noi di vedere pazienti trattati da anni con farmaci e poi hanno la celiachia o hanno l'iperparatiroidismo primitivo o hanno, che so io, un Cushing subclinico? Beh, anche questo bisogna che lo consideriamo, ma questo deriva dal fatto che si cura la densitometria, non si cura il malato. Quindi è un atteggiamento culturale, come è stato sottolineato in una domanda dell'audience poco fa, che deve radicalmente cambiare verso questa malattia, e quindi nel nostro piccolo faremo il possibile per farlo cambiare, e anche voi siete invitati a farlo rapidamente. Concludo per dire che ci sono i farmaci sono stati detti nell'ultima relazione, ne abbiamo per tutte le scelte, c'è un menù ricco con vie di somministrazione diverse, effetti diversi, pochi effetti collaterali, spesso ipertrofizzati, comunque vanno gestiti come tutti i farmaci in modo adeguato, e quindi bisogna impadronirsi di questa terminologia, di questo menù farmacologico, non limitandosi a dare la vecchia vitamina D che tanto fa male a nessuno, ma che faccia poi tanto bene per l'osteoporosi. Sinceramente non abbiamo dati sufficientemente solidi. Con questo io ringrazio la Fondazione intanto per l'opportunità che ci ha dato di discutere di questi interessanti problemi, questo e altri nei giorni di stamattina e domani. Ringrazio i relatori per la loro disponibilità e per la loro sapienza e il loro equilibrio anche, e ringrazio tutti voi per la vostra attenzione. E con ciò concludo e vi auguro una buona serata.